So good morning everybody. First of all, I would like to thank Dr. Rajesh Mishra for giving me this opportunity and bearing with me with different changes in itinerary. Side by side, I would like to congratulate him for organizing such a wonderful event. I can see in the morning, Saturday morning, so many delegates are here to listen all the speakers. So I have been given this talk whether ultrasound can change or we can use ultrasound for a breathless patient, how to diagnose. Majority of time, we are restricted to either our stethoscope or chest x-ray because CT scan is not available at the majority of the places, all the places, and such a patient who is already breathless, sitting, taking deep breath, having air hunger, may not lie down to have a CT scan as well. So look at this x-ray. It's a usual x-ray you see in day-to-day practice. Can anybody tell me what it shows? Is a hazy on the right side, little haze on the left side. Usual story in our day-to-day practice, maybe some pneumonia, some effusion, whatever is on the right side, some pneumonia on the left side. We'll see how it turned out with a ultrasound. So earlier people used to say that lungs are major hindrance for the use of ultrasound at thoracic level. This was published in way back in 1992 in the Harrison. So in a textbook, it still says that lung is not suitable for ultrasound, but reality is not same. Like you can see in the intensive care medicine, 93 it was published that it can be used. Ultrasound can be used in intensive care unit and it has got excellent results. This is another paper which shows that there is a deep impact of the ultrasound in intensive care unit. This is again an international evidence-based recommendation for point-of-care lung ultrasound. They were published in Intensive Care Medicine 2012. And my whole presentation is based on these guidelines. I think there is some problem, it's cutting. So, lung ultrasound is based on the fact that every acute disease, it reduces the lung aeration. So, whatever is happening to the lung acutely, it will change the lung aeration pattern. It will change some surface, lung surface, and it will generate a distinct predictable pattern on the ultrasound. So aeration change is the most important thing. That is why my patient is breathless, because he is not getting full aeration. And all these three things, they allow the diagnosis of conditions, and not only diagnosis, they allow the monitoring of these conditions as well, whether pneumonia is resolving, it is increasing, whatever it is. We'll show you in next slides. This is again a review of literature where they have compared it with different things. It can avoid referral CT scan, it can limit bedside radiographies, decrease radiation doses, safe, diagnose pulmonary edema, COPD, diagnose pulmonary embolism, helpful in chest trauma, cardiac arrest situation, acute dyspnea. These are different values of the sign. You can see they have compared with the CT scan as a gold standard. The specificity and sensitivity in majority of the cases is more than 96 or 97%. Coming to little bit how the image generation takes place in the lung ultrasound, there are two types of images. One are real images. It could be normal images, could be pathological images. There are certain artifacts. Normal artifacts, pathological artifacts. And what we do, we just study the artifacts. So majority of time the lung ultrasound is based on the study of artifacts only. This is the image which is generated. I am sorry, some part is cutting. So you can see top of this screen, the skin is there. Then the subcutaneous tissue is there. Then this black area. Can I have pointer? Okay, I'll try to. This area is the rib. Can you see this blackout? This white margin is the rib margin. This blackout is the rib. And then this is the pleural surface. And you can see this white shiny pleural surface is sliding. So what is happening? Visceral pleura is sliding over the parietal pleura with each respiration. That is why this white line is generated and is a shiny white line which is moving. Here you can see this sliding is more prominent. These are two ribs, one rib, another rib, and this is the sliding. So lung is sliding, pleura is sliding, both the pleura is sliding over each other. With this sliding, what is happening? The ultrasound beams are going there, reverberating, because air is a poor conductor. Air does not pass through the ultrasound beams. So whenever there is air in the alveoli, it will bounce back. And can you imagine when you throw a ball, it takes multiple spins, bouncing back, going down, bouncing back. So same way ultrasound beams also happen. And that is why we find a multiple A lines. So these multiple A lines are the artifact of this first line. So this first line of the pleural line is the original line, and these all horizontal lines are artifact of that line, duplication of that line only. But these are different lines. As you can see, they are again arising from the surface of the pleura, but they are not horizontal lines, they are vertical lines, they are sharp, laser-like lines, they are crossing all the things, and they are going down up to the base of the image. So they are there because there is an increased wetness in the lung. So when the alveoli becomes wet, it could be a intra-alveolar bleeding, it could be a thickening of interstitial tissue, like it happens in the pneumonia and ARDS. The thickening of interstitial tissue membrane takes place, and because of that increased wetness, this B lines arises. Okay, they are simple. E lines, as I have already discussed, wherever the air is, ultrasound beam cannot penetrate that. These E lines, if your patient is having surgical emphysema because of any trauma, any cause, then you will find these lines right from the skin, arising from the skin. And here, ultrasound is failure. We cannot penetrate beyond this. So we cannot study anything. Again, another pathological condition, like try to appreciate here. In previous thing where there was a slide, this is a one rib, this is another rib. This is the pleural surface. This white shiny is pleural surface. But try to recapitulate the older image. There was a sliding in the previous image. Here you can't see any sliding. Lung is almost static. You will see some flickering. These flickerings are conducted flickerings of the heart beating pulsation. So this is a lung slide. It indicates that lung is not moving here. Lung is a viable lung. Lung is an aerated lung, but it is not moving at all. It could be because of endobronchial intubation, it could be because of mucus plug, it could be because of anything, but lung is not moving here, or patient is in apnea. But mind you, lung is viable, not moving lung. So coming to practical uses, try to correlate these two images. Here you can find only flickering is there, no sliding. Here you can see pleura is sliding over each other. So this lung is immobile lung, sliding is absent, lung pulse is present. Here you can see is a mobile lung, sliding absent, lung pulse absent. So this is an endobronchial intubation. My tube has gone down into the right side, left side. That's why right side is not moving at all. This is a paper which was published in Trauma, Injury, Infection and Critical Care Journal way back in 2001. Where they have discussed the sonographic diagnosis of a pneumothorax inapparent on the plain radiograph. Like this radiograph is cutting, but you can imagine at this area, this is more lucent area. But if you compare in the CT scan, again this area is more dirty looking, but again there is a small pneumothorax here, which nobody can find with this type of X-ray. Let's see what happens in the ultrasound. Like if you put the ultrasound beam, ultrasound probe at this junction, where the healthy lung is also there in that window, and the lung where the air is pneumothorax is there all in the same window, you can find this type of picture. Here you can see pleura is sliding, lung is moving, but here there is no lung movement because here there is no lung. This white line is arising because of the pneumothorax only. So this area not moving because there is no lung. There is only static line because of the air in the pleural cavity, but here lung is moving. So it's very good tool to small occult pneumothoraxes. Coming again to the sonographic sign of the pneumothorax, they include presence of the lung point, as we have seen in the last picture. Lung point is the junction of healthy area and diseased area. Then absence of the lung sliding, absence of the B line, and absence of the lung pulse. So all the indication of the viable lung, if they are there, along with area where there is no lung movement, we can say that this is a point. So lung ultrasound more accurately rules out the diagnosis of pneumothorax than the supine anterior chest radiograph. What is happening majority of time in ICU, patient is already lying down. So we cannot do a erect AP view, PA view, where you can identify the air. Normally what happens, air goes up So in a standing patient, erect patient, air is coming at the upper side. But what happens in a lying patient in ICU? Patient is lying like this. So all the air will accumulate around the anterior chest wall. And whatever left of the lung is there in the posterior area, you will find the X-ray film of that area. So you may miss the small pneumothorax in a supine patient. But with ultrasound, you can pick up that very well. Coming to most common, another thing which we face in daily in ICU, that is pulmonary edema. What happens in the pulmonary edema? Uniformly, both the lungs get wet. So if you find this type of picture where the B lines are there arising from the pleural surface, right from the pleural surface here, and going down up to the border of the image, you can know that this is a wet lung. If you find this wet lung pattern all over the area, right from the upper lobe, middle zone, lower zone, front, back, everywhere, you are sure that we are dealing with a bilateral disease. It has to be a pulmonary edema. Coming to another interesting thing, diagnosis of pneumonia in emergency department. Many times in the chest X-ray, what we have seen in the previous X-ray, sometimes it becomes very difficult to differentiate between atelectasis, pneumonia, consolidation, effusion, just looking at the X-ray. But with ultrasound, we can identify that very well. Like here, consolidation is there. This is as you can see, this is the liver, this white line is a diaphragm, this is a consolidated lung, which normally we call hepatization of the lung because it is looking like a liver, consolidated liver. And there is a small amount of the effusion, very easy to diagnose with ultrasound. Another important finding, what happens in a pneumonia, there is no volume loss because the alveoli are consolidated. The terminal bronchiole architecture is well maintained. So air is going in and out, going in and out. There is a shunting. There is no volume loss. That is what you can see here. You can see this dynamic air bronchogram. Air is coming into these terminal bronchioles and going out. This is the hallmark of any pneumonia. So if you find this type of picture in any ultrasound, rest assured it is a pneumonia. You are not dealing with atelectasis, it is a pneumonia. I'll show you how atelectasis look like. Again, here you can see, we call it shred sign. What is happening here? This is a smooth pleural surface, but this is not shiny because this is a collapsed lung. There is no air. That is why it is not shiny. Here you can see a shiny line, but this shiny line is not a smooth line. This is a fragmented, shredded line. Just because there are certain areas with pneumonia, consolidation, certain areas are normal. That is why this is called shred sign. Shred pleura, there is an area of consolidation, no doubt about it. Look at this. What happens at atelectasis? Atelectasis, volume loss is there. Everything, whatever air is there, it is entrapped. So there is no movement of the air. As you can see here, these are the static air bronchogram. There is no movement in these bronchograms. Just air is entrapped. Effusion, not very difficult to diagnose. Coming to another landmark paper which was published in 2008 by this gentleman Daniel Lichtenstein from France, where they have said the relevance of the lung ultrasound in a diagnosis of acute respiratory failure. And since the acute respiratory failure, you find your patient cyanosis, so have they given the name of a blue protocol, mimicking with the cyanosis. What they have said, as you can see here, they have said they have depended these lung sliding, if it is present or absent. If it is present, look for the B lines. So you can rule out the rule in the pulmonary edema, you can rule out rule in the pneumonia, you can rule out rule in the pulmonary embolism, you can again rule out rule in the pneumonia, COPD, asthma, pneumothorax, and probably pneumothorax. I don't want to go much detail into this slide because it's a complicated thing, and blue protocol requires itself a 20-30 minutes talk on that only. But I just wanted to sensitize you what ultrasound can do in your clinical practice and how your clinical decision can change with use of ultrasound. So how good is the blue protocol? 90.5% diagnostic accuracy was obtained just by looking at the ultrasound images. Just imagine 90% diagnostic accuracy just looking at the ultrasound images. Combination of these with history, physical examination and other investigation, you will come close to 100%. Specificity for each disease, 94% or greater. Sensitivity for each disease, 89 or greater. Whereas in the pulmonary embolism, it is 81% sensitivity. So, what we can do with this lung ultrasound in diagnosis of acute respiratory failure, the blue protocol, what we can do in this blue protocol, we can diagnose status asthmaticus COPD. What we'll get in that? Predominantly bilateral A lines with lung sliding. Mind you, COPD patient, status asthmaticus patient, aeration is no problem. Lot of air is there in the lung. Lung is mobile. So lot of A lines plus mobile lung. 89% sensitivity with 97% specificity. Pulmonary edema, wet lung, predominantly B line with lung sliding, because lung is mobile, so lung sliding will be there, B lines will be there. 97% sensitivity and 95% specificity. But mind you, these wet lines, wet area should be all across the lung. Anterior, posterior, upper zone, middle zone, lower zone. Pulmonary embolism, normal lung ultrasound plus positive DVT, around 81% sensitivity and 99% specificity. Pneumothorax, predominate A lines with absent lung sliding, maybe with or without lung point. 81% sensitivity and 100% specificity. So if you want to rule out pneumothorax, it's one of the best modality, better than ultrasound, comparable to CT scan. Pneumonia, predominant unilateral B lines with abolished lung sliding. What happens? Lung sliding is abolished in pneumonia because consolidation is there. So many times you won't find the sliding of the pleura. Then alveolar consolidation with or without pleural effusion, 89% sensitivity and 94% specificity. This type of picture, if you find this type of picture predominantly on upper zone, lower zone, both the side, could be COPD, could be asthma, you can rule out pulmonary edema in these patients. Predominantly B lines, mainly on one side, it rules out cardiogenic pulmonary edema, because we know cardiogenic pulmonary edema has to be a bilateral problem, not a unilateral, so it has to be a pneumonia. Again, coming back to our previous patient, previous X-ray, just wanted to show you how you find what when we put an ultrasound machine on this patient. Recent image is cutting here, you can see that is on 4-5 days back image. So I'll tell you, this is on the right side there is a right lower zone image, on the left side left lower zone image is there. If I'll go back to the X-ray, right side is more affected than the left side. In the left side I was not able to find much thing, that is why I magnified the view. As you can see here, I'll just try to elaborate what is going on here. This is the diaphragm, this is the liver, this is the shaded margin of the pleura. A small effusion is here and few B lines are arising from here. You can see the laser-like lines. So again shred sign is there, looking more pneumonia, minimal pleural effusion, consolidation, maybe pneumonia. Look at the left side. Again, this is the diaphragm. This is a magnified view. This is the diaphragm. Below diaphragm there is a liver, and you can see there is a beak-like thing. This is the just terminal part of the lung which is coming into the recess, costophrenic angle. And this is looking like a consolidated lung. You can't see a shiny line here. This is again shed sign. So let's see what happened. We put NIV to this patient. This patient was breathless, low saturation, was not able to lie down. We put NIV to this patient. And what happened after 2 hours of the NIV? You can see at the right side, hardly any change. So it confirms that right side is pneumonia, because in the pneumonia, I cannot recruit pneumonia in 1 hour or 2 hours. On the left side, you can see, now that beak is gone, it is replaced by the sliding. You can see the sliding is here, shiny sliding. So I am confirmed that on the left side, it was the atelectasis. With the use of NIV, it has opened up. So this type of image generation and correlation with clinical condition will give you clinical accuracy, and your diagnosis and management can change. So just to conclude, ultrasound marries the human hand to the digital age, allowing the examiner to interrogate anatomy and physiology with the instantaneous visual gratuity. The thing is, you are able to see what is there right there. It is one of the most promising modality for the bedside respiratory monitoring, and its use should expand in the future. Thank you very much.
Thank you, Dr. Govind, for